Our next panel is the balloon effect, the public health consequences of class-wide scheduling. And I will pass that over to Dr. Sheila Vakharia.
Hi, everybody. Thank you so much for sticking with us today. I'd like to take a moment to introduce my esteemed panelists. So we have with us today Dr. Dan Ciccarone, who is a board-certified clinician in family medicine and addiction medicine. In his position as professor of family and community medicine at the University of California in San Francisco, he has been principal co-investigator on numerous NIH co-sponsored or sponsored public health research projects, including his current heroin in transition study. He is a recognized international scholar on the medical, public health, and public policy dimensions of substance use, risk, and consequences. He is an associate editor for the International Journal of Drug Policy and recently edited a special issue on the triple wave crisis of opioids, heroin, and fentanyl in the US, and I'll be inviting him to speak a little bit further about that. And then we also have Dr. Ryan Marino, who is a medical toxicologist, addiction medicine specialist, and emergency physician in Cleveland, Ohio. Dr. Marino serves as an assistant professor at Case Western Reserve University School of Medicine. He received his MD from University of Pittsburgh School of Medicine. So as we kind of kick off this panel, I'd actually really like to invite Dan, Dr. Ciccarone, to give us a little bit of a grounding in the current overdose crisis within the broader context of overdose trends in the United States. I gave a brief glimpse in my earlier remarks, but Dan has some really interesting framing to offer us in terms of really looking at this current moment. So I am going to share a slide that he gave me access to kind of set the stage for our conversation. So go ahead and take the mic. I can't hear you. I'm sorry. I don't know if anyone else can hear you.
Can you hear me now?
Yes, excellent. Thank you.
All right. Sorry about that. So hi, everyone, and good afternoon. Happy to be here. Thank you, Sheila. So to start us off, I just want to show you all the bad news. I mean, we're talking about bad news. We're talking about increased overdose deaths, but we often have a short time frame. We often have a time frame of what is the drug of the moment? What's the one that's causing us problems right now? What's the current scare? What's the current moral panic, if you will? And fentanyl does fit into the paradigm of a moral panic. But I want to now just step back and show you the bad news of deaths due to drug overdose over the last 40 years, or actually 38 years. If we look at the picture on the left, we can see drug mortality curves for various drugs. And you see a little bubble here, another wave there, and it all seems to be escalating. Now, if you look at the curve on the right, you can see that escalation. It is an exponential curve. This is the worst case scenario in public health, where you see a disease entity that not only is increasing year by year, but is increasing exponentially year by year. And what this tells me is two things, right? And they're both bad news. One is that there's an unknown driver of drug overdose in the United States, right? There's something that we don't pay attention to, that either because we haven't recognized it yet, or we simply have a blind side to it. And that blind side, I'm going to hypothesize, is social, economic, racial injustice, social and economic disparities in this country that drive drug use, drive drug potency, and drive overdose deaths. The second thing that I'm going to say, and again, it's bad news, is that what could possibly cause a 38-year exponential rise in drug overdose is that our drug policies are actually making the problem worse. We're actually putting fuel on the fire, okay? That by trying to do mass incarceration, by trying to do a folly of drug supply controls, we've actually made the problem worse. And so with those two, I'll say that's my opening statement, and I look forward to more questions.
Thanks so much. So also within this context, Dan, I am going to invite you to speak a little bit further, because there's a few constructs and theories that I'd like for you to also kind of bring to the awareness of our audience. First and foremost, you are kind of highly cited as the person who really started pushing us to thinking about this crisis, at least in the current moment, as a triple wave crisis. Can you explain what you mean by the fact that we are in a triple wave crisis and perhaps already in the fourth crisis? What does that mean, and what do you think contributed to that?
So the triple wave is the last 20 years of that 4 years crisis. The first wave of overdose deaths are due to the opioid pills. We're well aware of that phenomenon. There was an oversupply. The pushers were the corporations making and manufacturing and distributing the opioid pills. But then we tried to clamp down on it. So again, a classic supply side paradox where we put a lot of supply side pressure on reducing physician prescribing. We sued a lot of the manufacturers and distributors. We've cut back on the volume of pills that reach Americans by over 40%. And so we see a decline, a leveling off, if you will, of deaths due to opioid pills. But what did that push? What is the balloon effect, which is the title of this panel today? The balloon effect was deriving energy toward heroin use, heroin distribution, heroin use, and heroin deaths. And then the fentanyl wave comes in as a third wave. This is a relatively new wave in this 20-year phenomena, starting around 2014. And fentanyl, because it is a new substance, because people are unaccustomed to it, because of its potency, and I'll argue further, because of the vicissitudes in the number of analogs and their potencies, is driving an unprecedented, historic rise in overdose deaths. That's the triple wave. The fourth wave is now stimulants are coming in, being mixed with fentanyl, usually through choice. There's maybe some accidental mixing as well, and that's driving the fourth wave of overdose deaths.
Thank you so much for clearly just kind of articulating some of those terms and setting the stage for us. So I'd like to now pull in Dr. Marino, Ryan, to speak a little bit about something that he has actually kind of gained a little bit of a reputation about in certain corners of the internet, in really dispelling and challenging and myth busting around fentanyl. So, some of the earlier presentations, mine included today, really just talked about some of the ways we've really, framed and talked about fentanyl, its effects, and what it does. Can you talk a little bit about, some of these headlines about overdose based on physical touch alone, or inhaling it because it became airborne? And is that really possible?
Yeah, so I think fentanyl myths and misconceptions have really kind of taken on a life of their own. And without including them in the conversation around fentanyl, we're kind of doing a disservice here. So in my role in the emergency department, I can't say how valuable fentanyl is to me as a medication. In treating pain, it's much more favorable in its effect profile than a lot of other opioids we use. And it's just overall kind of a great and indispensable medicine. But what I've seen recently, and probably increasing over recent years, is I will actually have patients now who come in, maybe with a broken bone kind of poking out through their skin, are turning down fentanyl. They don't want their pain well controlled. They don't want kind of a safe and well-established drug. And this is because of these myths that there are. And so it's probably almost every day, at least once a week, that we're hearing some sort of report. Someone is touching fentanyl, going down. There's some law enforcement officer who was performing a routine traffic stop and had all of these horrible things happen to them. And the only way they got better was they gave themselves Narcan or naloxone, the antidote. But the problem is that none of this is true fentanyl toxicity. And so in my role as a medical toxicologist is knowing kind of how drugs work and understanding the pharmacokinetics, the chemical properties. And so fentanyl does not absorb well through the skin. There is a fentanyl patch that's available on the market as a medicine, and this is not necessarily fentanyl per se. It's fentanyl mixed into a solution. It takes more than 13 hours to reach steady state concentrations in the human body, which would be a therapeutic dose, not even an overdose. And again, we're talking more than 13 hours and something that is not actually just fentanyl. And there's also this myth that it kind of gets into the air and can aerosolize, and fentanyl, based on its physical properties and chemical properties, does not do that well. And this is kind of played out into the scenario that this could become a weapon of mass destruction. And we have not seen this successfully weaponized, with the exception of one very questionable incident in Russia. These drugs just do not work like that. And so me and some other collaborators actually looked at the role of misinformation, and just from May through December of 2019, there were 551 news reports in the United States that we found putting out misinformation about touching or inhaling fentanyl. And of these 551 articles, which is about 2 a day, I think, based on that short time period, there were 70 million Facebook shares, or 70 million Facebook users were reading or exposed to those articles. And inaccurate statements from government sources were actually shared 10 times more than accurate sources on fentanyl. And so other people have looked at this phenomenon as well. And while these people are having true symptoms, it's more likely to be a result of kind of the fear and the scare tactics, the overall kind of boogeyman of the day that fentanyl has become. And looking at these law enforcement officers, whoever has reported these symptoms, there's never been any testing that showed any fentanyl was in their system. People have done a very conclusive job at looking at the symptoms that are reported, and they're usually actually the opposite of kind of opioid toxicity, where people get rapid rates of breathing. And we know that opioids suppress your breathing, increased heart rate, palpitations, anxiety, fear, these kind of things that we actually use opioids to treat in people who are at end of life or having kind of severe medical issues. We can use opioids to make you not have fear, to make you not worry about your breathing. And so none of this is consistent with opioid toxicity. This myth is really out of control. And for whatever reason, it keeps getting put forth as kind of fact, when the facts show that it actually is the opposite and is totally incorrect and false.
Thanks so much, Ryan. So I want to pass the mic back to Dan, although Ryan, please feel free to jump in if you feel like you have something to contribute. I mean, Dan, you've been in this space for decades now, and you've seen drugs du jour come and go, and drug hysteria or sensationalism come and go. Obviously, one of the comparisons that we are making today is often kind of hearkening back to crack. But can you highlight some other instances of kind of drug sensationalisms, other drugs that have kind of came into public awareness, really only had a minimal geographic impact or very minimal impact altogether, but that have had similar kind of stoked similar fears?
Oh, there's been plenty of them. I don't know where to start. I mean, a local one from back in the day was when MDMA came out, and MDMA is a great drug. It's a wonderful drug. People really like it. There were the raves, there was, mass use. All of a sudden became like the thing. I mean, we have to think about, one of the causes of these various drug bubbles and cycles we've seen is the fact that people like the drug, right? And everyone hypothesized that it was going to cause this problem and that problem, and the sky was going to fall, and not much came out of the rave phenomena. Yeah, a few people got dehydrated, and some people got serotonergic syndrome and stuff like that. But, we do often go, we have, the society does have a philosophical, puritanical root to it. We do like to judge. We do get a little bit sort of bent out of shape. Now, I will say, based on my 20 years doing this, there is a lot of concern around fentanyl. We're not making this stuff up, right? So there is a genuine mortality curve here and a mortality problem. The thing is, it's better than we are at this point. We can't pull out our old tropes about trying to put the genie back in the bottle, trying to strong arm other countries to do something that we want them to do. The real truth is, we have a demand concern in this country, a challenge in this country. We need to address this as a public health problem. We need to work on stigma to allow people to come into clinic sooner, quicker. And we need harm reduction strategies, as the gentleman from Vocal was saying so eloquently earlier, because this brings people in and invites them in. And then ultimately, we need policies that address the economic and social and racial problems of this country that are drivers. We need a long-term demand side solution to this problem.
Yeah, and just to jump in really quick here, I mean, I think to emphasize what Dr. Ciccarone said about the supply side only interventions, as well as this kind of fear-mongering boogeyman approach. I mean, we can look at cannabis as a much older example where the same thing happened, and we saw the development of synthetic cannabinoids. And in recent years, the more popular synthetic cannabinoids like K2 and spice have had the same thing where they are now banned, prohibited at state and federal levels, and people have moved on to newer synthetic cannabinoids that are having even worse consequences. And this is something I see both in the hospital and getting reports through the poison center. Every new iteration is worse. And the same thing with the opioids, as we saw when you take away the pill supply, the prescriptions, they're probably, while it wasn't ideal, they're safer than the heroin market. And we've done a really good job of getting rid of heroin, and that was replaced with fentanyl and fentanyl analogues. And so now if we take away the fentanyl, which I'm sure is totally possible, what is going to fill that void? It's probably just going to be something worse.
Thank you. And so, all of these myths and fears really motivate sometimes really extreme policy choices, right? So including the class-wide scheduling, state level implementation and enactment of even harsher penalties. We see that. Can you talk about some of the other examples, and some of the ones that come to mind for me, and I'm wondering if you'd be willing or interested in speaking about, is, this proliferation of what we know of as drug-induced homicide prosecutions, and how those have actually also disproportionately impact people who use on the ground, and it feeds into some of this fentanyl sensationalism. Would either of you?
Yeah. So our criminal justice policies related to drugs have just led to mass incarceration, as has been already mentioned. It has a huge racial disparities in that we've locked up a couple of generations now. We lead the world in terms of incarceration of our population. It's a backwards approach. We are once again realizing that it's a backwards approach, that it's not working. We need to try more enlightened approaches. There are other places that have far more rational approaches to drug policy that lead people to treatment who need treatment. There's a lot of people who don't need treatment. They either find their way to reasonable levels of drug use and pleasure seeking and not problematic levels. But those who do approach problematic levels, places like Portugal, many places in Europe, will gently guide people over toward an open door, right? The problem with our approaches, just as a philosophical point, is it just adds to stigma. Stigma makes people run, it makes people hide, it makes people engage in more risky behaviors. A public health approach says, we care for you, we invite you in, we're not going to judge you, right? And those approaches will increase the treatment population and lead to more personal and hopefully community-wide level successes. The issue we have right now is people say, well, isn't that also not working, Dr. Ciccarone? I mean, we give a lot of money to treatment. We give a lot of, some places give a lot of money to harm reduction. The truth is just not enough. It's just not enough. We don't have enough addiction medicine professionals. We don't have enough harm reduction programs. We don't give out enough needles. We don't give out a lot of naloxone, right? We have an evidence base that works. We need to ramp up the policy side to meet the demand. And this is a historic level problem. So we need historic levels of resourcing.
Thank you. Some would also say, and this I think goes along with this, but Dr. Bryce Pardo of the RAND Corporation, who recently last year released a book on fentanyl, some have argued that fentanyl is here to stay. What are some thoughts that you have about this? That this is kind of the new era of the drugs that are on the street, that we're going to see more and more synthetic kind of substances, and that we're slightly, that we're moving away from plant-based drugs. What thoughts do you have about that?
Yes, I reviewed their work for them. I like the book a lot. What Dr. Pardo and his colleagues at RAND have done. The one thing that we disagree on is one of the causal mechanisms. I actually think that I actually agree with the causal mechanism that fentanyl is coming in as a substitute for heroin. And remind you that we had a historic. If fentanyl never appeared, we would have had a historic level of heroin use and heroin consequences following the clampdown on the opioid pill phenomenon, right? So wave 2 would have been historic all by itself, right? But instead, fentanyl came along because there simply wasn't enough heroin to go around, believe it or not. And the RAND folks and I have a strong disagreement on this, but we'll see how the data falls over time. But fentanyl comes in because plant-based product is heavily pressured in terms of crop spraying and those kinds of supply side efforts. There's a limited number of source countries now. Some source countries have gone away, like the Golden Triangle of Thailand, Burma, Laos, or at least have been greatly reduced. So that limits the number of source countries producing heroin. So fentanyl's come in as a technological innovation. It also fits into what we understand from studies of alcohol and other drugs that have supply side pressures in the iron law of prohibition. And that is, as you put prohibition pressure on a drug class, what you produce is greater potency. Fentanyl is the ultimate example of that. In the alcohol era, it was you put pressure on beer, you create bootlegged hard liquor. In this case, you put pressure on heroin and you've created a monstrous wave of dangerous drugs. And the thing is, we're putting the problem with the sentencing effort is that it's putting pressure. If you put pressure on mother fentanyl chemical, which is fentanyl, you get 200. And some people have estimates as high as 600 fentanyl analogues that are out there right now. You put pressure on fentanyl analogues, what happens? You're going to see synthetic opioids of other classes we don't know because we're just giving them numbers like U47-700 and U98-900. The ingenuity of the illicit chemical market is enormous, right? Why add more pressure to it? We should reverse that. Get back to demand control, demand reduction, and harm reduction.
Ryan, would you like to jump in at all?
Yeah, I mean, I think I would second everything that Dan just said. It is kind of the iron law of prohibition just pushes things to be more and more potent. And I think we would have ended up at fentanyl regardless, is my personal suspicion. But when fentanyl came into the street opioid market, this was not something that anyone wanted. And I mean, just to give an example of kind of the potency here and this as a public health issue, what I was seeing in people who would come in, I mean, primarily overdoses is what I would see in the hospital. I'm not seeing people who are just using on their own, but it was about 50% pure heroin in kind of heroin. When fentanyl replaced heroin on the market, it's 1% fentanyl because it's 50 times more potent than heroin. When you look at that in terms of kind of making the mistake that your average street level dealer is going to do, if you're off by 1% there, that's an 100% increase in the dose of the drug. And so it makes sense that we're having these massive overdoses without anyone intending to do so. I mean, an error of 1% when you're measuring things on kind of like a kitchen scale in someone's house or basement or whatever is not unsurprising at all. So thinking of the legal consequences, the drug-induced homicide charges don't really make sense to me when this is kind of a minor human error that we should expect, and that's a result of our own policy that we've put forth for the past several decades, if not the last century. And so in my eyes, I mean, every drug overdose death is a policy failure.
Thank you. Thank you. Yes, that's such an important point. Dan, I'd like to invite you for a second to talk a little bit about your heroin and transition study and some of the early papers that you released as part of it, just kind of documenting and tracking when fentanyl began to emerge in some of these Northeast and Mid-Atlantic states, and kind of the difference between what was happening then and what's happened now in some of those same exact entrenched markets in terms of, the time being that people didn't know what to expect, but now there are some markets in which the default is to expect that fentanyl is part of the drug supply. But can you talk a little bit about what you were initially finding in those early days versus kind of what some of the differences are now in terms of how people are talking on the ground?
Yeah, thanks, Sheila. So one of the notions we have around a drug cycle or a drug wave, if you will, is that it's a popular drug. So I mentioned earlier MDMA, when it came out, people decided they liked it, and they told a friend, and they told 10 friends, and it eventually became a cultural phenomenon. Fentanyl is not a cultural phenomenon, right? And I want to be very clear about it. I'm so clear about it that I wrote several papers just to be redundant about the notion this is not a demand side cultural wave of a popular drug, right? A lot of people in the early days, when it came in, it was contaminating heroin, it was adulterating heroin, it was unbeknownst to low-level dealers, unbeknownst to the users. People were surprised, people were dismayed by it, people didn't like it. And then because of its persistence, I would say that popularity has gone from maybe 1 in 5 liking it or tolerating it in their heroin to maybe double that, maybe 40% now. And that's because fentanyl potency drives the demand for it, right? It is more potent than heroin, therefore people's habits have gotten deeper and people need the stronger drug now. That's one phenomenon. So slight, I would, not slight, but a doubling, but an increasing of popularity or likability or preference, if you will. But the other thing is, it is spread westward. There was a moment of about 4 years worth of moments where fentanyl was coming in as a supply side imposition east of the Mississippi River. So from Illinois on eastward, the industrial Northeast to the Mid-Atlantic, certainly Appalachia and the Midwest, upper Midwest, the industrial Midwest, heavily infected by it. And that was, and we didn't know why, but clear, at least to my historic brain, was that it was a supply side thing. Some sub cartel of some part of the Sinaloa cartel said, hey, we're just going to do this and we're going to ride with it in these areas, right? But that moment has been breached. Fentanyl is now everywhere. It's moved to the American South, the Southeast, and it has moved west of the Mississippi River. Differences, and this is still preliminary, more research needs to be done, as we like to say in research. Fentanyl is being sold as is. It's being marketed separately from the heroin, separate from the opioid pills, and we need to understand the implications of that.
Yes, thank you. One other, and thank you so much for tracking that. And I feel like also the map that I used to illustrate overdose increases over the past year also helped to kind of illustrate that dramatic increase on the West Coast. The other thing that I want to highlight that I feel like, Shantae was kind of alluding to that I'd like to hit home as well is that fentanyl doesn't have legs. People say that fentanyl doesn't have legs and it's changing their injection practices and their experiences of what it feels like. Can you talk a little bit about what it is, what you're hearing from people who use on the ground, what it's actually doing to change their habit, their drug taking habits, which means that our harm reduction structures need to actually be more responsive to these changing dynamics.
Well, this is where it gets complex and interesting, and I hope I don't bore the audience at all. But fentanyl is a short-acting drug. It lasts 45 minutes to an hour and a half for peak. And Ryan could probably add more nuance to that. But when we use it, when I say we in medicine, we use it as a short-acting, controlled, strong drug that if we run into trouble, it's either reversible or the curve just goes away, right? On the street, it's very interesting. We see both evidence of short-acting effect, where people in the early days, where it was kind of new, it was kind of different, people were injecting 5, 6, 7 times a day, and that was very unusual. Heroin is a twice a day or 3 times a day drug. But over time, people are injecting less frequently because it turns out that fentanyl has a chronic exposure to fentanyl has reduced renal clearance. And so we're actually seeing that some people do find that fentanyl has legs. Now, whether that's driven by individual genetics or individual pharmacodynamics is a little bit unclear, but it's a mixed picture. My point from worrying about, as a person who worries about overdose, is just the chemical vicissitudes and fluctuations in all this, whether it's going from fentanyl, which is 40 times heroin, down to acetyl fentanyl, which is 3 times heroin, going up to carfentanil, which is hundreds of times heroin, and then back to mother chemical fentanyl, whether it becomes a short-acting drug to a long-acting drug, back to a short-acting drug. This is upsetting people's metabolism. This is it hasn't been proven yet, but hypothetically, it's a strong hypothesis that the vicissitudes, which are we driving by drug policy, by the way, our supply side drug policy, the vicissitudes in fentanyl are what are causing a lot of the overdoses because people can't adjust to the drug that's in front of them that day compared to what they were using yesterday or last week. Hope that was more clear than muddy.
No, thank you. And so now I want to shift to Ryan in the ER for a second. So you know, you've been practicing in the midst of all of this. You know, what are some of the things that ERs can be doing better when responding to overdose? And what are some of the broader policy lessons that you think that we should be taking to really push forward a more evidence-based public health approach to working with folks who've experienced overdose or who are at risk of overdose? What are some things your ER does?
Yeah, so I mean, I think there's a lot of things that we can be doing, and I think just first, right off the bat, some of the things that we shouldn't be doing is kind of perpetuating these myths and the stigma that Dan has also talked about. And the myths themselves probably come from a place of stigma, whether we realize it or not. And to perpetuate them is also continuing to increase the stigma. So the idea that touching or breathing fentanyl, that it somehow can be contagious or that you can overdose through a secondhand exposure is one of those myths. And so, I mean, I see people who will not touch someone who has overdosed. They will not resuscitate someone who's overdosed. I've walked into a patient I was following in the hospital and saw staff members stuffing towels under the patient's door because the patient had just overdosed in their room and no one wanted to go in and resuscitate them. And so those kind of myths really scare me because it leads to a lot of real harms for human beings. And even if you're a little more cynical than that, this increases healthcare costs just through kind of the actual medical harms, but we're now seeing things like fentanyl-proof gloves being sold, fentanyl blocking sprays, those kind of things, which are all have no basis in science and are, I mean, to just be frank here, are total scams and made up. Things that we should be doing is kind of treating these people like anyone else, like anyone with any other medical condition, and treating this as the public health crisis that it is. If someone has an overdose, we have a good drug that reverses most overdoses most of the time, and that's naloxone or Narcan. And I think this should be, I mean, first, it should be in every emergency department for sure, but it should also be out in the community. And then the other big thing that we can do is getting people linked into treatment a lot easier. And things like buprenorphine and methadone, which buprenorphine has the brand name Suboxone or Subutex, those are probably the best things you can do for people who use opioids who are interested in getting into recovery from them. And so that I have a clinic where we prescribe medications for people who use opioids. And one of the biggest things that I see is that people, instead of getting into treatment, get taken to jail or prison. And so they don't get access to those medications, and then they're left kind of out on their own. And this is a very vulnerable population to begin with. As we talked about a lot of times, I mean, people are using because of a lot of socioeconomic, other kind of disparities in their life, and taking away their one access point to an evidence-based treatment is going to create a lot more problems and put them right back out there where they're at probably increased risk of overdosing. And there is actually good scientific evidence that shows that people who are incarcerated who have opioid use disorder, whether they're incarcerated for that reason or not, when they're released from jail, have a much higher rate of dying than the general public, than people who are using opioids who do not go to jail, and then people who were released from prison or jail who do not have opioid use disorder.
Thank you. Can you talk a little bit more about the importance of using medication when it comes to treating folks and supporting folks, or providing them with an option for medications such as buprenorphine and methadone? Can you tell us a little bit about what's distinct about those medications and how they help people who have dependence, and what that impact can be when it comes to overdose prevention in the future?
Yeah, so if you think of kind of like addiction as a medical condition, and in a lot of cases it's a treatable medical condition. So we have these two medicines, methadone and buprenorphine, and at the end of the day, the reason people use opioids or the reason people develop addiction kind of comes down to receptors in your brain. And so these medications work on the same opioid receptors that heroin, fentanyl, whatever other opioid would be using, but they have more favorable profiles. And so for methadone, it's kind of a once daily thing. It will occupy those receptors. It prevents people from getting cravings. It allows them to kind of live their life. You don't have the ups and downs of something like fentanyl. And so people can function totally normally as long as they get their once daily medication. And buprenorphine too is the same. It's usually once or twice a day. It just sits on those same receptors. And buprenorphine is a little different because it's actually not a full agonist, so it doesn't have the same full opioid effect and can prevent people from having overdoses. But both of these medications actually prevent overdoses if someone were to have a relapse or recurrence of their use. There's been studies that show people have changes in the parts of your brain that are affected by addiction, where their brain will go back towards what we consider to be more normal functioning if they're on these medications. And so the big and harmful myth is that these medications are, quote unquote, just replacing one addiction with another. And that's not true, because we can actually look at the functioning of someone's brain on a functional MRI and see that the center that was disordered while they were addicted to fentanyl has reverted back to a normal functioning portion of the brain on methadone or buprenorphine. We see that people are having steady daily functioning. They're able to kind of go out, have jobs, drive their car, all of that stuff that when you're on fentanyl, because of the very short duration of action, like we were talking about, you get kind of this intense effect, and then very quickly it's out of your system. And so over time that leads to withdrawal, and your day is kind of spent trying to prevent that withdrawal. So a once daily medication that prevents that and allows people to just function at a normal level. I mean, it's like, for me, when I take my blood pressure medication, I'm not having the headaches and stuff that I would have if I wasn't taking it. It's just like any other chronic condition. For people who have diabetes and take their insulin, they don't have to worry about kind of overdosing on sugar, so to speak, where you can get very sick if your blood sugar is not controlled. It's really very similar for opioid use disorder.
Thank you. So I'd like to ask you all about 3 specific harm reduction informed policy proposals that we at DPA have been talking about extensively, and I'd love for you to weigh in, and we even have someone asking about this as well. In terms of other policy proposals that we could advocate for starting tomorrow, we at the Drug Policy Alliance are talking about the need for safer consumption spaces or supervised injection facilities as a potential strategy. And I'm interested in hearing a little bit about maybe kind of where each of you are at. But in terms of other really like on the ground, we could start with this immediately, are trials for other injectable opioids, such as heroin-assisted treatment, or what is also known as hydromorphone-assisted treatment and Dilaudid. And we've seen some initiatives around the world with these kinds of policies. And then lastly, this idea of increasing access to drug checking equipment so that people can be better informed about what drugs they are taking. Are either of you interested in talking about any of those policy responses and how you feel about them, what they mean? I know we only have about 7 minutes left, but I feel like, again, in closing a public health panel, I think it's really important for us to kind of close with public health solutions.
All right, do you want to go first?
Yeah, so I mean, I think when I see, Dan has mentioned this already, but seeing people who use drugs, not everyone has disordered drug use, not everyone has addiction. What the big problem is that drugs that are available on the street are unsafe. And that's where fentanyl comes in, carfentanil. We see all of these overdoses. One day you might be getting a stable dose of oxycodone. I mean, years later, you've switched to a stable dose of heroin, and then from one day to the next, you could be buying carfentanil. And so that's how people die. It's not just from the consequences of being someone who uses drugs or from using drugs. So in terms of harm reduction, making things available like fentanyl test strips and like safe use sites, no one has ever died in a site where their use is supervised. That would be wonderful. In the hospital, we give people very potent opioids. We give people fentanyl analogues even that are more potent than fentanyl itself in anesthesia. And these people are monitored very closely. They're on monitors. They have trained nurses there who can give them naloxone, Narcan if they have an overdose from these medications. And the same kind of thing is what we see in other countries where these safe use sites have been implemented. But certainly decriminalizing access to things like syringes that are still illegal in a lot of places and considered drug paraphernalia, those kind of things go a long way. Most of the patients that I'm consulted on for addiction in the hospital are there because they have some sort of horrible complication, like an infection in the valve of their heart, just because they didn't have access to basic things like sterile water, a clean needle, or an alcohol pad. And these are kind of penny interventions that cost pennies that could prevent someone from needing 60 days in the hospital and open heart surgery. So I think we really do have to kind of focus on that. And at the end of the day, if it isn't about kind of treating people better and being more kind to people who use drugs, there is a significant economic impact that comes into play here.
Thanks so much, Ryan. Thanks so much. Dan, you want to hop in?
Yeah, Ryan, I agree with everything. So just briefly, the evidence base for supervised consumption spaces is incontrovertible at this point. Multiple countries, multiple studies over a couple of decades now. They work, they save lives. Nobody has died on site. They are only socially and politically controversial. They are not medically controversial. Places that are willing and ready to do that should move forward. The feds just need to get out of the way, frankly. The next notion I would say comes under surveillance, right? The idea that we understand the drug problem based on toxicologies of people that have died. That is delayed data. That is sad data. It's unfortunate data. What we need is an understanding of how the drug supply is changing in the moment. Drug checking is a cheap, readily available technology for an individual to use. I would also advocate for large entity drug surveillance so that a city, a county could know how is its drug supply changing in the moment. This problem is not going to go away. Synthetics and the undulations, these vicissitudes that I've been talking about are not going away. We have shown using crime lab data from Ohio that if you understand the drug supply and its vicissitudes, you can actually predict overdose. You can send out warnings that says, hey, the fentanyl potency curve just got worse this week. Everyone be on guard. Supervised consumption spaces will work. Surveillance will help. Ultimately, we need to level out the drug supply field, allow people to have more steady state in their brains. That'll prevent overdose. And whether we do that through hydromorphone prescribing or buprenorphine, which is a wonderful leveler, or methadone, will be up to our courage and our ability to think creatively. This historic crisis requires us to act more creatively and more boldly, period. Thank you.
So we have about 2 minutes left. Are there any last remarks that either of you feel like you didn't get a chance to make? Anything that you have to add that just came to mind? Or are we ready to pass it along to our next panel?
I'll just jump in that, stigma makes all of this worse. And a criminal justice approach magnifies stigma. It harms people. It worsens the current situation. And it drives this 38-year exponential curve that I started with.
Thanks, Dan. Ryan?
Yeah, I think to reiterate everything that's been said, thinking of this as a public health crisis, which it is, this is tens of thousands and in the past few years, hundreds of thousands of people dying, every death entirely preventable. We need to treat it from a public health perspective. We shouldn't be treating it from a law enforcement and criminal justice perspective.
All right, well, thank you so much for everyone for tuning in. And I will pass it along now to Holly or Yana to keep things moving along. Thanks again so much, Dr. Marino and Dr. Ciccarone, for your expertise today.
Thanks, Ryan. Thanks, Sheila.
Thank you, everybody. Thanks.